Hello, the title of my presentation is Caesarean section scar ectopic and the role of ultrasound. Ectopic pregnancy occurs when the fertilized ovum implants on the outside of the endometrial cavity. In the first trimester, ectopic pregnancy is the leading cause of maternal death. NICE Guidance 2019 found that in the UK, the incidence of ectopic pregnancy to be 11 in 1,000, with maternal death rate of 0.2 per 1,000. Although 2/3 of those deaths are associated with substandard care, the most common ectopic implantation site is the fallopian tube. However, 10% of ectopic pregnancies implant in the cervix, ovary, myometrium, interstitial portion of the fallopian tube, abdominal cavity, or within a caesarean section, as seen on the current diagram. Sometimes the pregnancy is never visualized on scan and is known as pregnancy of unknown location. Caesarean section ectopic pregnancy is one of the rarest forms of ectopic pregnancy, accounting for 2% of all ectopic pregnancies. It's a form of abnormal implantation of embryo within the myometrium and fibrous tissues and a previous scar on the uterus, particularly following a lower segment caesarean section. It's not easy to diagnose, as presentation can be too variable and can be mistaken for low-lying and uterine pregnancy on ultrasound unless careful inspection of the surrounding myometrium is made. Some of the signs and symptoms of ectopic pregnancy can be seen on the current screen. However, some women with ectopic pregnancy are asymptomatic and are diagnosed at point of ultrasound. The case study I'm going to discuss today is patient A. She is a 44-year-old female with a less common caesarean section scar ectopic. Past medical history: gravida 6, para 2, previous ectopic 7 years ago leading to right salpingectomy, previous myomectomy, laparoscopic surgery for endometriosis, 2 previous C-sections, known fibroid, natural conception, a last menstrual period made at 5 weeks and 4 days, positive pregnancy test A&E, positive beta HCG. On transfer to the gynecology ward, the patient was hemodynamically stable. She was complaining of mild to moderate left iliac fossa pain and back pain. She was assessed by the medical team. On examination, she had mild lower abdominal tenderness, worse on central suprapubic area. Speculum examination was performed with consent and showed closed os, no vaginal bleeding, and no cervical tenderness. Patient was admitted and urgent ultrasound was requested to rule out ectopic pregnancy. An initial ultrasound was suggestive of caesarean section scar ectopic. Due to the gestation age and patient symptoms, it was determined that transvaginal scan was the most appropriate to assess the location of pregnancy for patient A. Transvaginal scan was performed with consent and adhering to local infection control policies. Initial scan showed antevertebral uterus, endometrial thickness of 8 mm, low within the uterine cavity, adjacent to the C-section scar, is the irregular gestation sac measuring 3 by 6 by 2 mm, mean sac diameter 4 mm, making it 5 weeks and 0 days. Within the gestation sac is a yolk sac but no fetal pole. Left ovary contains a hemorrhagic cyst, the right ovary not identified. No adnexal mass of free fluid. A caesarean section scar ectopic pregnancy cannot be excluded on scan, suggests medical review. When performing an ultrasound scan, it's important for sonographers to follow guidelines and code of practice set out by the Society of Radiographers and the British Medical Ultrasound Society 2021, which covers confidentiality, patient dignity, infection control, safety, ethical, legal and professional issues. Upon meeting the patient, it's important to introduce yourself and inform the patient of your role as a student and gain consent to perform the scan under supervision. Ensure to check patient's full name and date of birth before explaining the procedure to the patient. Effective communication is the ability to listen, convey interest, give compassion and empathy, to provide knowledge and information to the patient. Effective communication is an essential aspect of all healthcare. The Royal College of Nursing, the Royal College of Obstetricians and Gynecologists, and the British Medical Ultrasound Society all emphasise the importance of effective communication, stating this can have a positive impact on the efficiency of the appointment, the quality of the scan, and the experience of the patient, and is vital for informed consent. There are many different types of imaging methods, each one using a particular type of technology, and differ how well they demonstrate what's happening in different body tissue. Diagnostic ultrasound has become widely used imaging modality in early pregnancy owing to its lack of ionizing radiation, relatively inexpensive and easy accessibility. Ultrasound, especially the use of transvaginal scan, is considered as gold standard in the diagnosis of ectopic pregnancy, allowing early detection of intrauterine or extrauterine pregnancy, offering either reassurance or early medical intervention. Shetty et al. Argued that transvaginal ultrasound to be the single most non-invasive diagnostic testing, stating that it can even be used as a single alone test. However, NICE Guidelines 2019 suggested the most accurate method is using combination of transvaginal scan and serum beta HCG when the diagnosis of intrauterine pregnancy cannot be confirmed. The Royal College of Obstetricians and Gynecologists 2016 and NICE Guidelines 2019 both advise on the use of transvaginal scan when making a diagnosis of ectopic pregnancy. The use of 2D ultrasound combined with colour flow Doppler can enhance the diagnostic accuracy of caesarean section scar ectopic, as the presence of feeding vessels can be detected. However, the heating effect caused by the colour flow Doppler must be considered as a safety issue if the thermal index levels rise above 1.5 or higher, as per Beamer's 2019. MRI scans, although offering more detailed images, are more lengthy and costly process and are not suitable for patients who are hemodynamically unstable. MRI scans sometimes require the use of gadolinium-based contrast agents, which are not recommended in early pregnancy as their safety has not been established yet. Cassata et al. 2017 and Jordan's et al. 2022 both argue the use of MRI scan is not considered to add value in the diagnosis of caesarean section scar ectopic, which was the case for patient A, as the appearances of caesarean section scar ectopic are essentially the same as those described on ultrasound, but ultrasound is more readily available. MRI is often used as a problem-solving tool when ultrasound fails to identify an intrauterine pregnancy or identify the location of pregnancy in relation to surrounding organs. 3D ultrasound is another imaging modality that has been argued in the literature to have a higher accuracy in identifying ectopic pregnancy, therefore increasing early diagnostic rate and improving patient outcomes. However, as with MRI, 3D ultrasound is not readily available, therefore not suitable for emergency cases. According to the Royal College of Obstetricians and Gynecologists 2015, 3D ultrasound takes longer to perform, therefore is associated with higher power output than that of 2D, which is not in accordance with the Alaris principle. Furthermore, Looney et al. 2021 states the use of 3D in early pregnancy is not recommended as a standalone clinical tool and does not replace 2D ultrasound. When comparing images of patient A to that of a normal intrauterine pregnancy, we can see the major difference an ultrasound scan can show. On the first two images, we can see a normal intrauterine pregnancy in both planes. In comparison to patient A's images, we can see an empty uterus, clearly visible endometrium, empty cervical canal, gestation sac at the region of the caesarean section. The patient was informed of the potential caesarean section scar ectopic. Images were discussed with consultant radiologists for gynecology, who advised a rescan in a week. As the patient was hemodynamically stable, she was discharged home with a repeat beta HCG in 48 hours and a rescan in a week. A beta HCG hormones remained static, and rescan confirmed delayed miscarriage 16 days after the initial scan. However, scan findings were still suggestive of caesarean section scar ectopic. Medical management of ectopic pregnancy was commenced. There are various interventions that have been proposed in the literature over the years, but there is no consensus on the optimal therapeutic protocol for the treatment of caesarean section scar ectopic, and the treatment approach depends on various factors like the gestation age, hemodynamic stability of the patient. Recent research supports any method that removes the pregnancy and the scar, and to reduce morbidity and to promote future fertility. Glenn et al. 2018 argued that laparoscopic and transvaginal approaches are believed to be the first options for caesarean section ectopic, although continuous research is required to identify the optimal approach. The patient was given intramuscular dose of methotrexate as per protocol. As her hormone levels were still going up slowly, she was given a further dose of methotrexate. This time, she had it as a local intragestational sac injection under ultrasound guidance. The patient was followed up with serial beta HCG day 4 and day 7 post methotrexate and weekly betas till her hormone levels came down to negative. NICE Guidance 2019 sets out the following criteria for the medical management of ectopic pregnancy. However, this guideline is more applicable for women with suspected tubal ectopic or PUL, pregnancy of unknown location. As previously stated, there is no set definitive protocol for the treatment of caesarean section scar ectopic pregnancy.